everybody for joining us here today for one of our bleeding edge innovation grand rounds. And as I was just explaining to our speaker, this is our opportunity really to hear from national and internationally recognized experts in their field, people that have really demonstrated and serve as role models to our students and to us here at Carle, Illinois, about how technology and innovation really intersect with medicine and surgery in different ways. And so for that reason, I'm very pleased to introduce Dr. Bederson here. Dr. Bederson received his MD and residency training in neurosurgery from UCSF, followed by many other training experiences, but also fellowship in cerebrovascular surgery at Barrow Neurological Institute. He is the Leonard I. Mallis MD and Corinne and Joseph Graber Professor and System Chair of the Mount Sinai Health System's Department of Neurosurgery, and is widely recognized as one of the leading surgeons in his generation for skull-base and cerebrovascular procedures, performing over 4,000 of these operations to date. He co-founded the Neurosurgery Simulation Core, and I think we're going to hear quite a bit about that. It's really a digital technology resource group that is dedicated to developing these types of augmented and virtual reality technologies in clinical neurosurgery. And in 2019, he was named as the distinguished Gazi Yasargil Lecturer for the American Association of Neurological Surgeons in the Congress of Neurosurgeons Cerebrovascular Section. He also received the Jacobi Medallion, which is one of the highest honors bestowed by Mount Sinai's Icahn School of Medicine in 2020. So for all these reasons, and for, as you can see here, his title slide, we're very much looking forward to hearing about your work and this intersection of AR and VR for these types of brain surgeries. So please join me in welcoming Dr. Bederson here.
Well, thank you.
I'll turn that over to you.
Yeah, thank you so much, Dean Boppert. It's a real pleasure and honor to be here. And I'd also like to thank Anant Naik, who came up with the idea, and whom I had a chance to meet at the White Coat ceremony about a month ago. Although the title of this talk is to focus on AR and VR, I want to cover a couple of other topics as well. Here are my disclosures. I work with industry, some industries, and these are disclosed here. The objectives here are to give you a bit of an overview of neurosurgery disease states, to review the concept of time-dependent versus resource-intensive treatments, and a centers of excellence model of care that drives research. We'll then get into how VR versus AR versus navigation has applications in brain surgery. And I hope that I can touch a little bit on neurosurgery as a crucible for med tech innovation. And last but not least, I hope that I can slightly embarrass my daughter, Maria, who is a first-year student at Carle, although I'm sure I'll probably embarrass myself more than I embarrass her. We had the chance to visit your unbelievable campus last month. This is, my wife is Isabel Germana, who's also Maria's mom, and she's also a professor of neurosurgery at Mount Sinai, and her sister Lucia is a medical student as well. Maria got her start early on in science, accompanying me to the hospital at a very early age and competing for access to the scientific papers and x-rays and clinical material, just like any other good student would do. So there have been some really interesting changes in the healthcare landscape over the past few years in the United States and elsewhere. And one of them is a merger fever that has led to the conglomeration of very large healthcare networks. And this has a lot to do with the finances. Here you can see a slide showing the bond rating, showing the greater health of systems rather than standalone hospitals. And I believe that you have experienced the same thing in Illinois. And so this has led to tremendous consolidation of the healthcare landscape. And here you see what has happened in my neck of the woods. When I joined Mount Sinai, only this old, ugly, rusty building was here. Neither of these other buildings were here. And I showed this slide to demonstrate the rapid growth, but I blinked my eyes and a few years later, there are other buildings going up. And I know the same thing is happening where you are. So there's a tremendous growth related to consolidation of the healthcare market. Mount Sinai right now is a very big healthcare network. You can see the pink buildings demonstrating our locations in and around New York. And of course, we're surrounded by peer institutions like Columbia, Cornell, Memorial, and NYU. So it's a target-rich environment, if you will, for healthcare. And yet it's still become a very large health system with 42,000 employees. Mount Sinai is New York City's largest private employer. To give you some sense of scale, Delta Airlines before the pandemic had 80,000 employees. I am very fortunate to be the 8th chair of the Department of Neurosurgery, which is not a young department, having started in 1914. And during the time that I've been chair, the department has grown just like the health system has grown to a fairly large department of neurosurgery. We have somewhere between 45 and 50 faculty at the moment. And here you can see a number of our faculty, our residents, and fellows. And yet, even with all those people, we don't have nearly the staff to take care of all the patients. And so we're heavily supported by neurosurgery advanced practice providers, mainly physicians' assistants, but also nurse practitioners. We actually have 135 in neurosurgery at the moment. And that's a real change from when I was training. It's a busy service, performing about 5,000 to 6,000 cases each year. And this number seems to be fairly stable over the past couple of years, notwithstanding this dip induced by COVID. Neurosurgery disease states consist of vascular disorders and strokes, skull base surgery, benign brain tumors, malignant brain tumors, epilepsy, pituitary neuroendocrine, peripheral nerve, pediatrics. It's a very diverse field in which, in many cases, these divisions are as different from each other in terms of training, technique, and technology as pediatrics is from geriatrics. So it's a very, very diverse field, and many times the training after the 7 years of residency involves fellowship, postgraduate fellowship. So usually most people spend about 9 years in training to focus on one of these areas. In trying to decide how best to deploy all of these resources that are required to do all those cases, one of the paradigms that I had to acknowledge was the concept that some disease states are time dependent. After a large vessel occlusion, every minute of delay before reperfusion results in death of 1.8 million neurons. And so large vessel occlusion is clearly a time dependent disease in which it would be very helpful to be able to project our treatments out into the community where those patients arrive. Whereas some disease states are not so time dependent and are more resource intensive. And in those, we can create centers of excellence that are built around both human and technological resources. So what this meant early on in the development of our program was that we had to convert the concept that every patient arriving at each one of our hospitals where we provide inpatient neurosurgery would be treated at that hospital. And what I noticed early on was that if you were to take each disease state, and here you see the list of vascular disease states, unruptured intracranial aneurysm, arteriovenous malformation, intracerebral hemorrhage. So if you look at intracerebral hemorrhage, although the total number treated is large, the number seen at any one of our health system sites was relatively low. If you could find a way to move all of those cases into one center, that would create a center of excellence in which you could then gain experience. You'd have more patients for clinical research. You'd be able to develop treatments. And most importantly, you might be able to attract the sort of talent that would be a world-class talent who might want to make their whole career around this disease state because there's be so prevalent. And so that's what we embarked upon, a concept of diverting patients with specific diseases into centers of excellence. And so if we continue with ICH, this is a big problem worldwide. As a result of focusing all of those in one location, we're able to recruit a world-class surgeon who has developed a new treatment, a minimally invasive endoscopic treatment called the Stereotactic underwater blood aspiration method, SCUBA. And what he showed and we showed is that when you do the evacuation this way, the outcome is actually time dependent. So what was once thought to be independent of time, we realized that when done properly and under the right circumstances, actually does better if you do it sooner. So as a result of focusing into a center of excellence, he developed a new treatment paradigm that has now become a standard that is rapidly diffusing throughout the world and changing the global conversation. This whole concept of centers of excellence and focusing diseases into these centers has really played out across our whole health system, and in neurosurgery has allowed us to recruit some of the best talent, I believe, that exists. I think other people are recognizing that. You can see US News and World rankings of our department with neurology, which has grown over the years. And during this same time period, Maria, our first year med student, also grew into a tremendous athlete, a competitive skier, competitive gymnast, a rock climber and mountaineer that grew into a medical student. So that's all great. We've been able to focus our diseases into areas of concentration and clinical centers of excellence. But that doesn't make the disease states any less difficult to treat. So this is a classic case of a medial sphenoid wing meningioma. And the problem is very clear. We've got to take this out because it's compressing the optic nerve. We cannot see the optic nerve, although we know it's here. We don't see it on this image. We do see the internal carotid artery. We're going to use all kinds of technology to try to remove this tumor. In fact, the use of technology in medicine is as old as medicine itself. And here you can see a visual list of the technologies used throughout the ages in medicine, all the way up to a time about 5 to 10 years ago. I had a chance last month to write an article for Science called Dramatic Innovations in Surgery, in which I was asked to outline some of the major problems facing the entire field of surgery, not just neurosurgery, and to try to focus on technological solutions to some of these problems. And in the first paragraph, I thought about this case I just showed you. And there's a problem that is just built into the way the body is built, and that is that we cannot see through the body, and yet we've got to spare very critically important structures that may be hidden by both pathological and normal tissues. And in the article, I talk about the use of AR, VR, and navigation linked heads-up display This is a figure from the article. And I hope by the end of this middle part of our talk today that I will have explained and described how we use AR and VR to solve that problem of seeing through tissues and seeing through the body. So this is the problem we want to solve. The tumor is here. We know that at the end, if we're successful, we will have taken the tumor out and spared the internal carotid artery and its branches, the optic nerve and the oculomotor nerve. And yet, because the tumor hides these structures, they are at risk. The instruments that we use to remove the tumor are very damaging and dangerous to those delicate structures. So how do we apply technology to help solve that problem? It's somewhat similar to the problem that sculptors faced, in the sense that you envision a hand or the beautiful anatomy that you want to relieve or remove from the structure. And the job of the sculptor and the surgeon is to remove the part that you don't want and leave the part that you do want. AR and VR have come into play as a possible technology to help these. I'm sure you all know this better than I do, but the difference between VR and AR is that in VR, there's no actual interaction with the real world, whereas in augmented reality, we're projecting an abstracted portion of the virtual world into the real world. This has been used for a long time in aviation with heads-up display, in which some of the critical information about runways and airways and other information, it can be projected onto a screen and overlaid into the pilot's field of view. And that's a good example of AR in my view. In my experience in neurosurgery, simulation and VR is very useful for planning and discussion. Navigation gets you where you want to be. And augmented reality with heads-up display helps you do the job better. I think of the process of the AR, VR heads-up display workflow as three parts. The first is to create a simulation. Think of the movie Avatar. And in this case, we combine multiple scans to create a virtual reality scenario. We then link that, like GPS is linked to the position of your car, we link that VR scenario to the anatomy of the patient. And then we take some of the information and inject it into a heads-up display into the operating microscope. Another way to think of this is to divide the phases of the workflow into the preparation, planning, and practice phases. And here you see some of the activities that we do in each one of those phases. So in preparing a VR scenario, we will take multiple modalities such as MR, and in the MRI, we will use multiple different sequences. Here you see a T1 contrast enhanced image overlaid and co-registered with a CAT scan that is done with intravenous contrast. And so we're going to then have the ability to overlay brain tissue, tumor, soft tissues, spinal fluid, bone, and blood vessels. And we'll then co-register these different types of information and create a VR scenario that you can see here, showing the blood vessel, the tumor, the brainstem, the midbrain, and here the brain has been subtracted. So here is a case, 71-year-old man presenting with ataxia and weakness, found to have this meningioma of the foramen magnum, grossly compressing the cervico-medullary junction and causing a deficit of transmission of both sensory and motor information through his pons and through his upper cervical spinal cord. This is the VR scenario, and here in this portion, we have emphasized bone, tumor, and blood vessel, which is very important. But now what we want to do is overlay the brainstem, and this will help us in planning our opening. Here we window in the brainstem, which you can see, and we can see very clearly what our window of opportunity is going to be surgically to get to this tumor while sparing the brainstem and the blood vessels. So this is very useful for my own planning, for discussion with residents and fellows, and also to show the patient. There are different companies that do this sort of thing. What I showed you just now was surgical theater, and this is how BrainLab does it. I work with both groups and have had a lot of success, I think, in dialoguing with their engineers and allowing me to influence the product that I think is going to help me do the surgery safely, and then getting that into my operating room and making it available for our patients. Here you can see the different vendors really showing how they manage this data.
Right, just this.
So this represents a simulation-based patient-specific consultation in which we have created a VR scenario, and the chief PA, Leslie Schlachter, is explaining to the patient and his wife, using VR and a 3D printout, what we have to do and what the situation is.
Now, right, just this top centimeter right here, where this is coming out, the cranial nerves come out of the brainstem, and all these little itty bitty foramen is where they come out and go to where they're supposed to go. Okay. All right. So ones that go through to the eyes come through here. The ones that go to the tongue come right through here. That's why we were having you do all those things, because all of the cranial nerves have their own little home that they kind of settle into.
This look on her face, I call the aha moment, because often the patient and their family never really understood what I was trying to tell them, even though I thought I might have given a brilliant description using CTs and MRs and so on. It's not until they see someone describe it using the VR AR that they finally understand it. By the way, I want to stop for a second, Steve, and just make sure that you guys are hearing me fine and that the message is coming through.
Yeah, thanks. This might be a good chance if people have any interim questions too.
Yeah,
that's okay.
That'd be great. And I'm a good halfway through what we're going to cover.
Okay.
Hi, this is Professor Kaskasavadis. I'm a faculty in engineering, and I am also a faculty in Illinois College of Medicine. So VR and AR has been my research for the last 15, 20 years, and I'm really impressed to see what you are doing. My question for you is, are you able to integrate fiduciaries and get high resolution mapping inside the clinic for accessing the tumor like you're showing?
Yes, yes, and in the operating room, and that's exactly where we're going. What I'm trying to show here is the general concept, the use outside the operating room, and we're sort of moving towards the operating room, and that's exactly where I'm heading now. Thank you for that.
Thank you.
I see there's a question in the chat from Dr. Greeley as well. What happens if the surgeon has red, green, or blue, yellow color blindness? Are those adjustable, those color scales?
That's a great question. The answer is yes. The answer is yes. We can assign any color that we want to the objects.
So I had a question too, and I think a lot of the rendering of these models, right, based on image data, CT, MR image data, allows you to kind of zoom in and out. But you know, coming back to one of the questions, the problems you posed from your article, that, you know, blood and tissue are opaque, right? How do we see through them? But I was thinking one solution to that is about the scale. So we have this ability through, you know, AR and maybe VR to really magnify the you know, the features, to be able to zoom in, for instance, or in essence, for us to become miniaturized, to be able to look at the tissue, you know, look at that tumor, you know, on this, you know, at a much finer scale. So my question is, like, with a lot of the, you know, Da Vinci systems, a lot of surgical robots, this ability where the surgeon can be immersive right, in that, but also change the scale. So essentially that tumor, that small centimeter sized tumor now becomes, as big as a person, and you're standing next to it, right? And so you can see finer details and maybe do this types of surgical manipulations where they no longer seem micro scale to us, but they seem macro scale. And I'm wondering if that's integrated into some of these technologies.
Yeah, absolutely. And I hope to demonstrate that.
Okay. Very good.
So why don't we try to get through these, and then hopefully that will provide a little more color to this. I'm not going to show this video, which just shows the patient himself describing how he felt this was a useful adjunct.
I was writing a note.
This is the concept of the heads-up display. And this is our cockpit. So getting to the question that was asked by the engineer earlier, how do we bring this from planning and so on into the operating room? And this is our cockpit in the operating room with the surgeon looking through the eyepieces. So this is equivalent to the windscreen of the airplane. And lots of digital information are projected onto screens out here. But if you want to make use of this information, until recently, you'd have to stop operating and look at the screen. It's a very distracting thing to do. You're deep in the brain and you don't want the distraction of stopping the operation. You want to inject some of this information into the eyepieces so that you can keep operating. But in order for this to be relevant, the first thing that has to be able to do is the machines need to be able to track the movements of your eyes and the microscope. And here you're going to see as the microscope moves, the navigation and the simulation also move. And that's because we're optically tracking the microscope, not only the XY axis, but also the Z axis, in which the depth of field and the distance, the focal distance, is being tracked. To give you a sense of what this looks like, I'll just paint the picture here. There's the patient. We're going to be doing a left frontal craniotomy. This is the view through the eyepieces. You see the skin marking that's done here. And we see the heads-up display that has been projected into the eyepieces. Here, the whole thing's projected into the screen. But what you're going to see as we walk up to the microscope is what you will see as a surgeon as you approach the eyepieces. And as you approach, there, you stop, and I'll show you one more time. So what you're looking at here is the scalp and the projection of the optic nerve, the tumor, and the internal carotid artery into the eyepieces in an anatomically correct location, which then can be used to help design the skin incision. This shows that as we increase the depth of the focus, if you look at the bottom left arrow here, we're increasing the depth of focus. This is by stepping on the foot pedal of the microscope. Here we're moving the microscope around, but we're also showing an increase or decrease in the depth. And if you now turn your attention to the top right, what you'll see is that as that moves, the heads-up display also changes. And so what this is essentially doing is tracking the eyes of the surgeon, because as long as you stay in focus, the machine now knows where you're looking as the surgeon. And again, this is what you see through the microscope. As you change the depth, here we're not moving the XY axis. All we're doing is moving the zoom in and out. Here we're zooming way deep to the skin, so we see the tumor and the optic nerves that we're going to encounter a little bit later. This gets a little too detailed into the concept of Z-axis navigation that I think I should skip. And likewise, the same here. This demonstrates a little bit of what the dean was asking. Here you've got a tumor that is approximately 8 millimeters or 9 millimeters in diameter, and we've magnified everything. And of note, the simulation, which is the green line, magnifies at the same rate as the optics do. So we're here at a fairly high magnification, demonstrating the border of the tumor. And this is now looking between the hemispheres and behind the optic nerves and between the optic tracts. This is a patient with an arteriovenous malformation that's deep in the brain, and our approach is going to be through the cortex. But this cortex is completely normal. And so what we see when we get into surgery is a normal looking cortex, but this is the outline of the AVM that you're going to encounter deep, projected into the eyepieces. So the surgeon then simply follows that outline deep in and eventually encounters the malformation. And this is what you see during surgery. And what you'll see is that as we magnify, not only does the optical information magnify, but the simulation magnifies, getting back to Steve's question before. This is a 47-year-old woman presenting with cerebellar findings, a giant tumor of the posterior fossa. We have to segment or paint the structures, and there are many ways of doing this, whether automated, manual, or in the future AI assisted. And now we're in surgery, and the first thing you're going to notice is that there's way too much information being projected into the eyepieces. All of these colored squiggly lines are very distracting to the surgeon. And so what we've learned is to specify the really important, crucial aspects at each time of the operation. In this case, we want to know the outline of the tumor, the location of the seventh nerve that's going to animate her face, and the location of the vertebral artery. Only those three items. And as the surgery progresses, we know now that the border of this tumor is up here, the basilar artery is deep. And as we get really deep, we see that this seventh nerve, which animates the face, is outlined, and we can confirm that with a stimulator that allows us to preserve this facial nerve and preserve function even after complete removal. And for this particular patient, who happens to have been Jeannie Gaffigan, the wife of the comedian, her facial nerve function was really important to her and also to me. And so having this sort of technology, I felt, and I strongly believe, was a significant benefit to her and to her outcome. I think I'm going to skip over the concept of intraoperative navigation update, but this deals with the problem of what happens if there's an offset between what the machine thinks and what is actually the anatomy. And what this is here is an ability to update the information during the operation and drag it into position that allows us to update a little bit better. A microscope is one way to operate, but we also use exoscopes. And here you see the difference between an operating microscope and an exoscope. This is basically a high-powered camera that's positioned behind the surgeon's right shoulder and focused into the head. And what you can see here is that the microscope gives a richer, more, a warmer visual representation, and also is easier to move. The exoscope gives a sharper, more crisp view, but it's more difficult to move. And so there are different surgeons prefer different ways of doing it. The endoscope is something that we use to remove tumors through the nose. And here you can see the concept of incorporating virtual reality and the endoscope. And what this shows here, and I'll stop it in a second, this shows the endoscope being tracked and the virtual reality rendition seen in the neighboring screen, allowing us to avoid these aneurysms that are projecting into the tumor and creating a very dangerous situation, but much helped significantly by the addition of the AR injection into the endoscope screen.
We present the case of...
I'm going to finish this part of the lecture, and we're actually almost done, with a video that lasts about 5 minutes that I hope ties all this together. This is created by my fellow, and it's narrated by Ray Feng, who's a third-year neurosurgery resident.
We present the case of a 45-year-old woman with a right clinoid meningioma diagnosed incidentally after a head trauma. Her neurological exam was normal at the time of presentation. The tumor was extending from the paracellular and cellular regions to the middle and posterior fossa. A CTA was obtained to further character.
Oh, I'm sorry.
We present the case of a 45-year-old woman with angiogram with capillaries encased and displaced by the tumor. A preoperative angiogram was conducted 2 days before surgery to devascularize the lesion and reduce intraoperative blood loss. The infralateral and meningohypophyseal trunks were coiled, resulting in reduction of tumor blush. Note the fetal origin of the right posterior cerebral artery. After the procedure, the patient experienced right partial third nerve palsy. Three-dimensional simulation allows neurosurgeons in training to explore the different operative angles, as well as to plan the bone opening while using the virtual reality goggles. Here, we can see in close detail how the tumor was encasing the internal carotid artery terminus, the origin of the anterior and middle cerebral arteries, as well as the posterior communicating and anterior choroidal arteries. The basilar and superior cerebellar arteries were in close contact with the posterior medial aspect of the tumor and laterally displaced. This 3D virtual model of the patient's specific anatomy can also be integrated with the navigation information intraoperatively to assist during surgical resection. The images of the CT angiography and MRI DICOM series were fused to co-register scans for preoperative planning and intraoperative navigation. Preoperative planning software allows for segmentation and 3D reconstruction of the tumor and critical neurovascular structures using the Smart Brush tool on the MRI or CT imaging. The segmented neurovascular objects can be highlighted in specific colors. Here, among others, we have segmented the tumor in purple, the internal carotid and the middle cerebral arteries in pink, the posterior communicating artery in blue, optic nerves in yellow, and the brainstem in green. This information can then be registered via navigation and displayed in the eyepiece of the microscope in an augmented reality fashion to optimize surgery workflow and avoid having to redirect attention to the navigation screen. The objects can be turned on and off during surgery to draw attention to specific structures intraoperatively and also limit attention blindness. The heads-up display has potential value during multiple stages of surgery, from as early as planning the skin incision to craniotomy design or dural opening. The microscope can be brought to the field to superimpose the tumor object over the patient's anatomy and confirm appropriate size of the pterional craniotomy. The dura was opened in a C shape and reflected anteriorly. When opening the basal cistern, special care must be taken to identify and preserve the superior medially displaced optic nerve, which can be seen outlined in yellow in the heads-up display before it becomes visible. While we continue to split the sylvian fissure and advance in the subarachnoid dissection to access the tumor, we have changed the heads-up display visualization from 3D to 2D. The augmented reality can be seen as distracting and interferes with the visualization of the surgical field. However, over time and with practice, the optimized number of segmented structures can be easily be integrated with the anatomic visual information. Here we have specifically outlined the optic nerves, the internal carotid artery, the middle cerebral artery branches, and the tumor. We start by carefully dissecting the tumor away from the branches of the middle cerebral artery. There is a superior and posterior offset of the heads-up display relatively to the patient's anatomy. The current software allows us to update the heads-up display information intraoperatively, but given that in this case there is just 1 or 2 millimeters of difference, it is not necessary to adjust it. Note that the solid lines represent the portions of the middle cerebral artery with a current focal depth or lateral aspect. At this point, a cortical grid was placed over the motor cortex to obtain continuous monitoring from the left side of the body. Transcranial motor and somatosensory evoked potentials were also monitored bilaterally since the beginning of the surgery. After gaining inferior access to the most anterolateral aspect of the tumor, we dissect the tumor away from the middle cranial fossa floor. The tumor has been debulked, and now we're progressing the dissection towards its superior posterior aspect and delivering it anteriorly into the expanded sylvian fissure. Again, we use our bipolar to dissect the tumor capsule and ultimately the sonopet to debulk the tumor. The display is also helpful to provide awareness of the lateral border of the tumor. Here we see the origin of the necessary to identify the posterior communicating and the anterior corridor arteries as they exit the tumor posteriorly. The heads-up display here outlined in blue is critical in order to provide situational awareness for the surgeon to identify these structures before seeing them with the microscope. This is one of the most important of the case since it is essential to preserve these arteries given the crucial anatomical brain areas they supply and the fetal origin of the right posterior cerebral artery. We confirm the patency of the vessels using the Doppler.
I'm just going to stop there and say that that moment of the case is the make or break moment, which is going to really determine the outcome for the patient. Those tiny little blood vessels, if you are not able to see them or catch them, if injured, will cause a stroke and a devastating problem. So I'm going to stop now on the heads-up display AR/VR and finish with a few slides on how we can extend the sort of development of technology into a program that creates innovation, creates companies and value for patients and for our institution. And this relates to a program we now call Sinai Biodesign. This is a program that started in 2005 when we were really looking at 3D modeling and simulation. And what I realized was that in trying to solve these problems in the operating room, I had a series of key industry leaders, CEOs of medtech companies circulating through my ORs to work with me to develop the technologies that I've been showing you. We spun out a company, a very simple company called Monogram Orthopedics, in which we thought that we could design a hip implant and 3D render it first. And what I then realized was that we could potentially create our own companies and create our own products and our own solutions. So the first problem that I tried to solve was the problem of a minimally invasive cranial access device, and ran home, drew a couple of designs, improved those designs, went into the shop and made a prototype from things out of Home Depot, spiffed it up a little bit, and then brought it down to our prototyping lab where we created a 3D print model in the rapid prototyping facility. We then engaged our partners at Mount Sinai Innovation Partners to search the literature and realize that there really was no such thing out there. We gauged the clinical market for this thing. We filed the patent, we got the patent, and realized that we had just prototyped a process for developing technological solutions and companies. We have since developed into a more advanced or more refined program in which we coordinate strategy with Mount Sinai Innovation Partners. We're embedded, Sinai Biodesign is embedded next to the operating room in the interventional radiology suite. And we've developed a process that leads, we hope, to translational grants, early licensing, and startup companies. We've got a number of companies in the works. Here you can see our pipeline. We've had quite a few faculty engagements. We have about 30 patents pending or completed, a number of grants, lots of papers, a number of students. And so I feel like we have begun to translate the process that we went through in developing those technologies with companies into a process that would allow us as physicians to partner with engineers to create value. I thought this would be of some interest and relevance to Carl, Illinois, because you guys have thought this through far better than we have. And I'm hoping that this you found somewhat useful and maybe would serve as a talking, a point that we could then share some discussion if we have a few minutes left. And I thought I would just finalize with some more embarrassment of Maria on her very first day of school many, many years ago, and the progression to the medical student she is today and beyond. So thank you very much for this invitation, Dean Bopart, and I hope that we can then maybe engage the audience for some more questions.
Wonderful. Thank you so much, Dr. Bederson. This is just, I think, an amazing set of experiences and technologies, and how you've really not only merged those with, the clinical surgical applications, but then, as you just described, this process, right, that really encourages that innovation and that process for new ideas and technologies. Yes, let's open this up. There's let me maybe start with some questions in the chat that were entered, and then we can open it up for some verbal questions. So one question that came about is there's a lot of, this is from Jessica Breitbarth, that there's a lot of surgical practice and planning around first 3D printing of structures and organs and prior to going into surgery, just to give that three-dimensional perspective. What do you do any of that in addition to the AR, VR that you've been describing?
Yes. The 3D printing I have found is useful in a couple of areas and not as useful in other areas. When the anatomy is bone anatomy, for example, complex spinal deformities, the surgeon and the patient seem to find it very, very useful to hold the spine in their hand, to look at the deformity and see where the instrumentation and screws and things are going to go. There are some limitations. The 3D printing takes a lot of time. There's a certain cost associated with it. And the more you get used to the 3D VR computer generated graphics, the less useful it seems to be. So there certainly is some use to it. Another area that it's very useful is in creating practice cadavers. They're not cadavers, but they're patient-specific printouts that allow you to use a robot, for example, to practice drilling and guiding and that sort of thing. So there are definitely some uses. I find that it's a little less useful than I would have thought to begin with. Where 3D printing really comes into play is in prototyping new instruments for use, as I showed in the MICAD, the minimally invasive cranial access. Turns out that 3D printing is a major milestone in the development of prototypes. And so having expensive 3D printers, particularly those that can print in hard plastics and metals, is really, really useful. I know you have that in spades over there.
No, that's great. Thank you. Another question. So how long does it take to segment and create the AR graphics from the MRI and CT data? And can that be done even in real time, right?
Yeah, great question. And the other add-on to that question is, who does the work? There is an activation threshold. What I showed today, I consider so useful clinically that I really would prefer not to do the case if I don't have that technology available that day. A lot of surgeons who have not used it yet don't necessarily agree. And one of the reasons is there's so much work involved in preparing the case. What we have found is that the more we do it, the simpler it gets. And the further and further into the workflow, we can get the ball rolling. Right now, our administrative assistants who don't have any formal medical background have been trained to know what sort of MR and CT image parameters are needed to generate a good simulation. And so even before I see the patient, they'll make sure that they come with the appropriate scans. If you have good scans, of course, you're going to get good simulations. Using the software that I showed you, it takes about 1 hour to do the sort of simulations that I just showed you. An experienced person needs about 1 hour. They don't need to be a fully trained physician to do that, but someone who's got experience with the software will take about 1 hour added time.
Okay, good to know. So, and a question related to that, this is coming from Al Smith, one of our students. How do you account for the brain shifts, a brain shift on dura opening, and also, you know, some sort of deformable registration algorithm, or how do you account for the difference between intraoperative and preoperative data?
That's great. A great question. Those were the part of the slides that I kind of skipped over. There is a new software called Intraoperative Navigation Update. And it accounts for a portion of the question that you asked, because there are really two different types of registration errors. One is when the entire body shifts relative to the registration between the 3D VR scenario and the actual anatomy. And the other is when parts of the anatomy change, either due to removal of a portion of the tumor, hyperventilation that will shrink the brain, or brain retraction that can cause shift, or drainage of spinal fluid that causes brain shift. The first one is the most common one, and it's often the one that is the most vexing, because you've done all this work and you find that there's an offset of 5 to 12 millimeters, and that is unacceptable. That 12 millimeters is unacceptable difference between what you need to see and what you expect to see. The new software allows you to reorient the navigation so that you can re-register during surgery very, very, very simply. So that takes care of that problem. The deformable structures that you ask is a much more difficult problem to address. And there are two ways to deal with it. Both involve re-imaging those portions of the brain during the operation and then re-registering. And the two ways we have of doing this now are intraoperative MRI and CT and ultrasound. And both can be used to feed into the machine and re-register the anatomy. But those are expensive technologies and time consuming.
Yeah. No, thank you. We got a number of questions keep coming in from the chat, which is great. There's one from Kesh Kesavadas. Is AR VR integration and this effort reimbursed?
No. There's something called interpretation of 3D images, which we code for, but it's really not reimbursed. So how do you pay for that? Well, I actually think that you pay for it by a shorter OR time and fewer complications. So there is, one complication will cost many thousands or hundreds of thousands of dollars, but it's very hard to translate that type of savings into convincing someone to either buy equipment or pay someone to use the equipment. Having said all that, I do think that as time passes, this will become a standard of care. And just like stereotactic navigation was not reimbursed 20 years ago, and it's now reimbursed, I think that VR or AR-based surgery will develop its own codes and eventually be reimbursed. I hope. Great question.
Yeah, thank you. So the questions are coming in. I want to open this up so it's more of a discussion. So maybe I'll ask the individuals to ask those questions verbally, if you don't mind. And I see Daniel. Daniel had his next question here. And if you don't feel comfortable or I can read the question. Let me know.
So my question was pertaining to the time-sensitive nature of mechanical thrombectomy. I was wondering how you could see this playing out in a stroke situation. And then also, do you think that this type of technology could be used to improve outcomes for posterior stroke patients who are known to have worse outcomes than anterior stroke?
Yeah. Well, there's a lot rolled up into that question, Daniel. I think what we have found is that for the time-dependent treatments like thrombectomy, we have to project our treatments out into the community. And so we created a program called the Mobile Interventional Stroke Team. It used to be that all our patients arriving at any one of those hospitals would be shipped to one of the two motherships. But if you've ever tried to cross the East River in the middle of the day, that could, even though it's like a couple of miles, could take 2 hours. And you will have lost your window of opportunity. So what we're now doing is incorporating advanced technologies in the ambulance to try to assist with the detection of stroke before the patient ever gets there. The first scans that are done when the patient arrives are being transmitted via telemedicine to our on-call stroke team. And as soon as we get word of something like this, we call Uber, and we have a suitcase that has some of the equipment that's needed, and at the outposts in Queens, the equipment to do the thrombectomy. And so frequently, once the patient is in the ambulance, our team will be in an Uber going there to meet that patient, and then everyone will be ready for the thrombectomy. For the posterior circulation case that you mentioned, yes, they have worse outcome. They also have a longer time than the anterior circulation. So if you can survive 90 minutes of an anterior circulation occlusion, you can survive 190 minutes in the posterior circulation. So although the consequences are more severe, the timing is a little more forgiving. We have not gotten to the point where I see this going next is the use of wearable devices that can detect changes in the impedance of the brain relative to ultrasound delivery, so that we can detect ischemic stroke, particularly large vessel occlusion in the ambulance, and divert those patients to the appropriate location. Great
Thank you
question.
so much. I really appreciate it.
Thank you. So Chris Ruard, if you'd like to ask your question next.
Yes. Hi, Dr. Bederson. Thank you for the presentation today. So one thing that I noticed early on in your presentation was how you geographically defined what a center of excellence is. And I was wondering, do you think that the integration of this AR, VR technology with some of the robotic guided surgeries that we're starting to see today could improve equity of access to the center of excellence level of care that you were describing?
Yeah. Boy, you guys are thinking big. I love that. Absolutely. Absolutely. I mean, the answer is just yes. And we are now working with the Icahn International Insurance Company in Ningbo, China, as well as in Kuwait, to do exactly what you are talking about. You know what the biggest issue is, Chris, is bandwidth, internet bandwidth. In order to travel those great distances, if you're going to actually do something on your screen and expect it to be reflected 1,000 miles away, you know, you've got to have very rapid transmission of information, or you've got to really decrease the amount of information that you need in order to have some sort of effective implementation. As it turns out, it looks like the easiest way to do this is going to be with endovascular, transvascular procedures, in which you're basically just looking at an X-ray, and all you're doing is manipulating a catheter. The simulators for endovascular work are rapidly advancing. And so I think that for places like Africa, where there may be a stroke, there may not be all the right people who are able to treat that case, but you could have the equipment there to do it, and train up the people in order to get the catheter in the femoral artery, for example. This to me is the one where I think we're going to see the greatest likelihood of improvement. And we might even do it in Queens or in Brooklyn, because it's still 2 hours to Brooklyn, 2.5 hours. And that's, you know, that's as good as a plane flight, because by that time the brain that is not being perfused is gone. So this is a great question. And I think there's so much opportunity for this technology to be used to improve access.
Great, thank you.
Thanks. Michael, looks like you're up next.
Hi, I'm Michael. I just wanted to ask, it seems that you have these high fidelity image overlays with your augmented reality. I was curious to ask about, like, you mentioned endovascular. If you're thinking about doing any procedures sort of entirely endovascular, maybe for a smaller tumor or something like that, especially with the uprise and uptick of like high fidelity guided catheters.
So primary treatment, you mean primary treatment via an endovascular route of intracranial pathologies is growing. And there are three ways that it's growing. One is when the primary treatment is injection of particles to reduce blood flow, then that's your biggest opportunity. So coiling of an aneurysm, that's an example of an entirely endovascular treatment. Stenting or flow diversion of a stenotic artery, entirely endovascular treatment. Occlusion of arteriovenous malformations. Normally, I mean, 5 to 10 years ago, we only had a 15% occlusion rate. Now that is rising significantly as the technology improves. The use of transvenous embolization for occlusion of AVMs is also resulting in greater cure rates. So for vascular pathologies, intravascular technology is ideally suited. The next phase is, can we use the blood vessels to get access to extravascular pathologies? I think that's really where your question is going. Tumors, for what type of tumors? Is there something like a radioembolic that we're currently working on that you could deliver intraarterially to the tumor that would deliver radiation therapy to it? Is there a way to get outside the blood vessel and then back in without causing a hemorrhage? And here's another great one. Let me see if I can show this to you. I know that I'm taking up way too much time.
Well, absolutely not. No, we have blocked this out to go till 1:30. So if you've got the time, we'd love to continue the conversation.
Yeah, I don't know if I have all the way to 1:30, but I don't think I'm going to be able to show you this slide. But think about going outside the blood vessel. You could do it mechanically, but what if the information or the pathology is electrical information?
Mm-hmm.
And electrical information readily passes through blood vessels. So there's a company called Synchron that Tom Oxley invented a device called the Stentrode. A Stentrode is an endovascular stent that has 16 electrodes embedded in it. We can implant that Stentrode in the superior sagittal sinus adjacent to the motor cortex. And in a patient who's paralyzed due to something like a myotrophic lateral sclerosis or paralysis, electrical information that originates outside the blood vessel goes to those electrodes, goes to a transmitter, and then they can operate a computer. We're at the point now where you can even translate those electrical impulses to speech. So that, you're right, I think, right along the right line of questioning. How do we get outside the blood vessel and use those blood vessels, which go everywhere, to get access to pathology? Not necessarily tumor pathology, but in that case I just gave you, electrical pathology.
Interesting. So please let us know, how much time you might have left, but there's a few more questions that we can get to. One actually relates to flow and fluid dynamics. Vish, would you like to ask your question there?
Sure. So thanks, Dr. Bederson, for your talk. So I was just curious, in the VR and the AR portion, if you've considered or see a benefit for integrating, maybe like other parameters relating to, maybe fluid flow, different pressures, intracranially, and then maybe how do you see that helping the surgeon as well?
Yeah, that's a really interesting question. There is a science around fluid dynamics. Many of the vascular pathologies involve turbulence and shear stress, as well as, all basic formulas like the law of Laplace that relate to the diameter and the wall tension and so on. What we're finding is that if you take intracranial aneurysms, for example, as many as 1% of the population have them. If you do autopsies, almost 1% of the population has it, but only a small fraction actually rupture. So what are you supposed to do when you discover an unruptured aneurysm in a patient with no symptoms? 99% of those will not rupture, and every single treatment carries risk. What the Japanese in particular have discovered is that by looking at flow dynamics, computed flow dynamics with non-invasive imaging, you can detect turbulence that generates shear stress along the vessel wall. And it turns out that shear stress is an incitement to inflammatory process in the vessel wall that leads to weakening of the wall. So by complex fluid dynamics analysis, they seem to be able to predict which patients are more likely to rupture and therefore warrant the sort of treatment that is needed to prevent the rupture, which carries risk. Does that answer your question at all?
Yeah, I was just curious about, in terms of integrating that into the AR portion of the, of the surgery, and if you've considered that. Or
Well, I would think that it's the AR portion, not as much, because AR is more about anatomy, but I think it would probably be more interesting to use AI to be able to predict which patients are at greatest risk of developing stroke, which patients need flow augmentation. If you're doing a thrombectomy, for example, when have you improved flow enough? So these are great questions. I don't have good answers to them, but I could certainly see as technology advances, we probably would want to use that information.
Thank you.
Great. Next question from Maria.
Hi, Dad. Thank you for sharing all those pictures. Everyone enjoyed them. I was wondering if you could talk a little bit more about the fellowship that you mentioned at the end and who it's open to, and just, talk a little bit about that. Thank you.
Yeah. Well, thank you, Maria. Sinai Biodesign is rapidly growing. We have a number of different types of fellows. Our basic concept is lifted from Stanford Biodesign, which essentially says that if you are a fellow, your main thing would be to adopt one of our projects, become the project lead, and over a period of 1 year or 2 years, bring that project from wherever you found it to an exit in which you could be the CEO of that company. And that's our basic model. We're granting 2 PhDs now, so we're collaborating with RPI, Rochester Polytechnic Institute, and RPI has given us 2 of their hotshot students to finish their PhD with us. They're going to be each spending 2 years. They're going to prepare their thesis proposal and do their thesis, and we will grant them together with RPI their PhD. And each one of them has their own project, and we hope that they will then exit our program with those projects and have the chance to bring those into the commercial world, as well as to get an assistant professorship somewhere, because our other goal is that we want to change the paradigm such that entrepreneurial engineers don't have to leave academics in order to do what they want to do, make the sort of money they need to make to survive, and also bring their ideas to fruition. So PhD students, medical students, we take medical students during a scholarly year who will do the same, but the intention of the medical student is to spend 1 year with us and then go back to complete their training. Virtually anyone who was able to get into Carl, Illinois, who has the sort of engineering interest that you have at your school, would probably be a highly competitive applicant to such a program. What might be fun to explore is something that could be done jointly with Carl, that doesn't take you completely away from where you are, but would still expose you to what we have and might expose us to some of the resources that you have as an engineering school. Then there are master's students. So we have a number of people in their at their master's level who we either grant the master's to or we contribute to it. And we collaborate with a couple of schools in the vicinity. CCNY, the City College of New York, is also now beginning to send students. So to us, students are the lifeblood, absolute lifeblood of the entire Sinai Biodesign. We call them fellows, but they're students. I hope that answers the question.
Thank you.
Wonderful. So I see two more questions in the chat. Dr. Musa,
Yeah.
if you want to ask yours.
Yes, thank you very much. Again, Dr. Bederson, thank you. This is obviously terrific. I think, so I'm an interventional cardiologist and Associate Dean for Research and Innovation. So you'll be hearing back from me, obviously, about your offer. My question, just a little bit not technical. You know, in cardiology, we have lots of augmented reality with structural heart disease, laying CAT scans, and always the critique we get, like your colleagues, show me the value. Do you foresee any small scale comparative trial to demonstrate, right, the quality or efficiency value of the work?
Okay. Now I have got to find the video that I didn't show. One of our most interesting projects is called Mitral Print. And well, first of all, I should say that in general, in the field that I'm in, we're almost always following cardiology. I don't know why that is, but cardiology always seems to be like 1 or 2 steps ahead in terms of the development of the technologies, the concepts, and so on. I like to think the reason that is that the heart is a far easier organ to work with than the brain because it's stronger. Like the valves, the tendons, the muscle is stronger, whereas the consistency of cranial nerves is like wet tissue paper. But I have often found that anytime I think of something, the cardiologist did it about 5 to 10 years ago. What we're working on now is a program called Mitral Print, in which a 3D printed catheter will be inserted endovascularly into the mitral valve to, in real time, measure coaptation pressures and basically the efficacy of the repair that is done in real time. And so although it's not a VR representation of it, the VR was used to create the analysis of the valves and then to create the catheter that then is inserted into the valve between it. So there's certainly an interchange that we have right now with cardiology, cardiac surgery, and the engineers.
Yeah, absolutely. We then got to work on making sure the heart doesn't move at its functions because the heart moving is a problem for us. But I think, absolutely, I think we have the mitral clip now, and obviously there's a lot of, robotic transcatheter. Let's hope Dr. Kesh here on the conversation. I think there's significant opportunities for collaboration, frankly. And I think we'll hopefully follow up. And again, thank you again for your time.
Thank you.
Exciting. Yes, I mean, it's even more wonderful when there's ideas and collaborations and that spawn from these discussions. I think we have one more question from Professor Shah in the chat.
Wonderful. Well, Dr. Bederson, thank you for taking the time to speak with us. There were many amazing technologies you spoke about during your talk. And what I was curious about is, how do you decide when a developing technology is ready for initial patient use, and particularly during surgical procedures, right? And the types of technologies you're speaking about. So I was wondering if you could comment on that from your individual level as a physician, and then also from the perspective of either the hospital system or the academic system and whatever oversight they have over those types of decisions.
Yeah. That is such a good question. And actually what I thought you were going to ask me was, there are so many ideas. How do you decide which ideas to pursue, to develop into, to try to develop into the new technologies? And one of the things that I run into politically is a little bit of anger sometimes when a surgeon or an engineer comes with what they think is a really great idea. And we've developed a whole process in Sinai Biodesign to vet these ideas. And we decide, either because the market is not good enough, there are too many patents out there that are related, or we have some belief that it's just so far away from reality that we choose not to pursue it in Sinai Biodesign, that can be very disappointing, obviously, to someone who brings that idea to us. So we've tried to become as transparent as possible in vetting these ideas for development. Once they pass through, there are two pathways towards human use. So we have a new project now called Pharynx Aspirator, which is going to be an attempt to suck out aerosolized particulates from the airway and make working in the airways and the nasal passages much safer for surgeons and nurses. And so we have a company that's interested. It's technology we've developed. We think there's a need immediately, given COVID and the risk and so on. There are two ways for us to progress with this, to answer your question. One is to go to the FDA and try to get an investigational device exemption called an IDE, and that will take a good year's worth of effort. The other is to convince our IRB that this is a no risk, that they can allow us to do an experiment, a first in human experiment, because this is a no risk exemption. So those are the two pathways to try something new if we think it's important, that we think that there's a good idea. And the reason this is important is that there's no company that will take our idea and try to run with it until we've shown that it can be done in human beings. So the company we're working with here, in this case, Stryker, they want us to do the work. They want us to show that this is doable in human beings. So I'm arguing with our IRB now that this particular one, the Pharynx Aspirator, deserves a no risk extension. I'll let you know how that goes. Otherwise, we've got to do an IDE. And how we prioritize those really gets back to the process that we started in the first place, which is surgeons and physicians are bringing these problems to Sinai Biodesign for solutions because they think those problems are really important. So we use our connections with the clinical people who are doing it to see the enthusiasm. And we show those ideas all around the world sometimes to get their impressions of our solutions. And when there's enough enthusiasm, we basically prioritize those. I hope that answered your question.
That was very helpful. Thank you.
Dr. Bederson, this truly has been wonderful. And we really thank you and appreciate the time that you've spent over the last hour or so with us, and your insight and answers to these questions and the glimpse of really, this future of this AR, VR work. I think there's lots of ideas that are coming out of this, and I think a lot of inspiration too, in terms of problems that, our students here and others can think about. So thank you once again. This has really been wonderful. And I'm sure Maria will not hear the end of this for a while, but it was wonderful to have that personal perspective as well.
Thank you, guys. It's been wonderful. I look forward to continuing the discussion.
Will do.
Have a great day. Bye-bye.
Take care, everyone. Thank you for joining us.